Now, Dr. Kamal Masaki is our first speaker for today, and she's a regular in the mini-med school because of her expertise, her communication skills, and her compassion. She's speaking on how she really likes working with all of us and improving the quality of our lives. So she's special. Today, she's speaking on a topic that not everybody talks about, but almost everybody has at one time or another. And that's those embarrassing leaks or incontinence. And also, Kamal wanted me to tell you that she does have to leave immediately after her talk. This is the first time she's had to do this, to go to a memorial, the Willed Body program. But then she'll come back if you have any questions later. So please welcome Kamal.
Ladies and gentlemen, it's very nice to see all of you again. I recognize a lot of you from previous mini medical schools, so it's nice to have the continuity. Geriatrics in general is a non-glamorous topic, and today I've picked one of the most non-glamorous topics among them, urinary incontinence. So these are the things I'll be covering today. Just what is it? How common is it? Some of the normal changes we see in aging. Some of the risk factors, the various types of incontinence, the tests and treatments, and then prevention and complications. So starting out with what is it? Well, this is some of the normal anatomy. So here we have the kidneys. The kidneys are what makes urine, and then these are the tubes, the ureters, which take the urine into the bladder, and then this is the bladder, and then it comes out through the urethra. So this is just the normal anatomy. Urinary incontinence is involuntary loss of urine. So you get leakages. It could be small amounts or it could be large amounts. It could be occasionally, could be once a year, or it could be several times a day. Unfortunately, this problem can really affect your daily life and your quality of life. It's a symptom of many conditions, not just one disease. So again, just like many things in geriatrics, you need to be a bit of a detective to figure out why people have this. It is unfortunately a very common problem. 15 to 30% of people in the community have urinary incontinence at one point or the other. Nursing homes, of course, this is much more common. 60 to 70% of people in nursing homes. Unfortunately for us ladies, it's twice as common in women than in men until the age of 80. After that, it kind of equalizes between men and women. But among the younger age groups, it's definitely much more a disease of women. And it's an expensive disease. The annual costs are estimated to be over $60 billion in the US. This is my drawing. I apologize for my lack of artistic ability. But this is the bladder, also called the detrusor muscle. The bladder is basically a muscle. And then this is the urethra. And we have the gatekeepers that prevent everything from the bladder from just coming out right away. So this is the first gatekeeper, the internal sphincter. And then this is the second gatekeeper, the external sphincter. And both of these have various controls, okay? So this is the emptying. So what happens when the bladder empties? Well, the detrusor muscle has to contract to squeeze out the urine. The internal sphincter has to relax. And the external sphincter, which is under voluntary control, this is the one that we can decide when we want to go to the bathroom. That also has to relax. This is the storage phase. So this is when the detrusor muscle basically relaxes. So it allows the urine to kind of fill in there into the sac. And hopefully, if it works well, your internal sphincter contracts, so the gate is working well to prevent the urine from leaking out. So when do we use these? Well, it's our nervous system that's controlling both of these. Storage is kind of the flight or fight response. So when I'm teaching medications to my medical students and my fellows, I'm usually teaching it that way, to say, well, when do you go into storage? It's when your sympathetic nervous system, your adrenaline is going. If you're being chased by a tiger, it's not a good time to go void right now, correct? So you go into storage mode, hopefully. And this is under a different nervous system. So all of the medications that we use for treatment of incontinence are doing one of these four things. They're either contracting the bladder, or relaxing the bladder, or relaxing the internal sphincter, or contracting the internal sphincter. Again, the different types of incontinence require different types of treatment. So what happens with normal urination? Well, the bladder is really a storage, right? It just stores the urine. The first urge to void is when your bladder is not completely full. Usually, when you have about 150 to 200 milliliters of liquid in the bladder, that's when you first get the urge to void. Now, most of us can actually control that. So let's say it happens right now, where you get that first urge to void. But you know you don't have to go right away. Usually you can just sort of forget about it, right? Until your bladder gets fuller. At some point, it gets to the point where you gotta go right now. Normal bladder capacity is about 300 to 600 milliliters. And normal voiding is when bladder pressure increases. So the pressure in the bladder is now greater than the internal sphincter, so you have to void at that time. And all of this is controlled by your nervous system, the brain and the spinal cord. So this is sort of the cycle of normal urination. On the top, number one, we've got that the bladder fills. Well, what happens? When the bladder fills, the detrusor muscle relaxes, the internal sphincter contracts, and your whole pelvic floor sort of contracts to prevent leakage. This is that first sensation to void. When your bladder is kind of half empty, you can see, right? It's not completely full. There's a little bit of urine in there, and you get a little urge, but you can control it by controlling your sphincter. This, when your bladder is almost full, this is when most people need to go to the bathroom. And then when you actually go to the bathroom, your muscle contracts, your pelvic floor relaxes, and you go to the bathroom. So this is normal. Now, what happens with aging? Unfortunately, in normal aging, even bladder capacity decreases. So, does everybody agree with this? The older you get? Yeah. I see a lot of nodding around the room. The older you get, the more likely you are to go more often because your capacity of holding urine is definitely less. The other thing is that residual volume increases. What is this? At the end of after we urinate, there's always a little bit of urine still left in the bladder. You don't completely empty. Not every drop is squeezed out. As you get older, actually, there's more left behind than when you were younger. So again, you kind of have that little half, it's not completely empty, so you can imagine it takes less to be put in before you need to have that urge again. Unfortunately, involuntary bladder contractions are also very common. Among people who have incontinence, 40 to 75% of elderly people have this, where your bladder suddenly contracts without you knowing about it, and then you can have leaks because of that. The other thing that happens with normal aging is urine output is shifted to later in the day. So what does that mean? We wake up more at night to go to the bathroom. Because instead of having your urination equally throughout the day, now it's kind of shifted to later in the day. And this is because of some of the hormonal changes that happen. In women, after menopause, we see this condition called atrophic vaginitis, where the tissues around the vagina get kind of contracted. And that can, again, contribute to incontinence. And in men, of course, the prostate can enlarge. So this is a normal prostate. You can see, right? This is the bladder, this is the urethra. The prostate is sitting right around the top of the urethra. And you can see this is an enlarged prostate. You can imagine how it's kind of squeezing that urethra and not allowing the urine to come out properly. So what are risk factors? Unfortunately, age is at the top of the list, just as with everything else. Being overweight as well. So sometimes we do recommend weight loss to people who have a lot of incontinence problems. Female gender is a big risk factor, and pregnancy and childbirth are also risk factors. Now, I have one child, and I had a C-section. Not my choice. I was instructed that I had to have one. So I figured, oh, okay, so that protects me, right? Because I didn't have a vaginal delivery. Well, unfortunately, no. Just the fact of being pregnant is a risk factor because it does things to all the tissues. It kind of relaxes the tissues down in your pelvic area. Of course, multiple pregnancies are a bigger risk factor. In females, menopause, you get a drop in female hormones. Unfortunately, just replacing the hormones, you might think that, right? If it's a drop in hormones, just take hormones and that'll take care of it. The studies have not been very effective as far as giving hormones for treatment of incontinence. In males, prostate problems get more common with age. And overall health conditions. As we get older, we're more likely to have things like diabetes, high blood pressure, diseases of the brain or the spinal cord. And smoking is also a risk factor. So the first step I take when I look at a patient with incontinence is first figure out, is it transient incontinence? That means something that's happened really recently, or is it established incontinence? It makes a huge difference to my approach to the patient. Usually, when it's transient, so it's just happened over the last few days or weeks, usually that's reversible. Something's going on to cause it. We need to find out what it is. We need to treat that, and most of the time, patients do just fine. If it's been going on for 10 years, a little bit more challenging. So that's when we need to kind of bring in our specialists. Yes, I do know how to spell. This is misspelled on purpose, but we use the mnemonic diapers with 2 P's in it to look at the causes of transient incontinence. So I'm going to go over each of these later, but we have delirium, infection, atrophic vaginitis, pharmacologic, which is medications, psychologic, endocrine, which is your hormone systems, restricted mobility, and stool impaction, so diapers. Delirium, what is this? Those of you who came to my brain health talk, I talked a little bit about this. Delirium is an acute confusional state. Often in the hospital, have you been to visit an older person in the hospital? Person who was completely normal mentally, and now they're incredibly confused. They may not even recognize you. They leave the hospital, within a few weeks, they're back to normal. This is a delirium. It's due to many acute medical conditions and very common in the hospital. Infection. Certainly bladder infections can cause sudden incontinence. You can imagine, right? Infection means there's a lot of irritation in the bladder. Anything that's irritated is going to contract more, and you're not going to have control over it. Elderly patients can present very atypically with infection. If you remember the signs of urinary tract infection, it's usually burning when you urinate. An older patient may not have that. So the only sign they may present with sometimes is an incontinence. So again, the physicians need to be very vigilant about asking more questions. Atrophic vaginitis, we talked a little bit about, women after menopause. Pharmacologic, when I have a patient who comes in with sudden incontinence, the first question I ask is, are you taking any new medications? And especially over-the-counter medications, because some of them, especially cough and cold type medications, can actually contribute or even cause incontinence. So that's the first thing I ask is, are you taking anything new? And stop that, and let's see if that takes away the problem. Psychologic, this is actually quite unusual. We don't see it very often. You have to have a very, very bad depression in order for it to cause incontinence, but it is possible. Endocrine, diabetes. We know that people who have high blood sugar or other endocrine problems like high calcium levels, they just have more urine. And so the more urine you make, the more likely you are to have incontinence and leakage problems. Restricted mobility. This is pretty self-evident, right? If you have a fracture and you're on crutches and it's hard to walk, if you've had a stroke, if you have Parkinson's disease and you're really slow, this is a really bad one, but restraints. You've seen people in the hospital who are tied down in bed. Well, anybody who's tied down in bed, how are they going to get to the bathroom? They're going to be incontinent, right? So anybody who can't walk fast enough to get to the bathroom could have a transient incontinence. Stool impaction, so really bad constipation can also cause this. You might wonder why. Well, remember, the rectum is right behind the bladder, and it can cause pressure on the bladder and can cause all kinds of things to go on there. So again, constipation can be very common in older persons and actually quite easily treated usually. Some of the common medications that we see, diuretics. What do diuretics do? They make you pee more. Well, again, you can imagine why they would be a very common cause of incontinence. Timing of diuretics is very important. I would never recommend taking a diuretic right before bed, unless you want to be up all night, correct? Again, cough and cold medications, you don't think of it, but it's a side effect that they might have. Some heart and blood pressure medications, too, can have effects on the bladder. Sedatives, antidepressants, many of the antidepressants actually relax the detrusor muscle and can cause incontinence because of that. Pain medications, and then alcohol as well. So all of these are things that we have to look into when we see transient incontinence. Now moving on to established incontinence. So these are people who've had incontinence for a while. And we divide them into these categories. I'm going to go over each one of them. There's stress incontinence, urge, overflow. Overflow can be two types, obstruction or a detrusor muscle, the bladder muscle is paralyzed or weak. Then there's functional incontinence, and all of these can present as a mixed category. Those are the tricky ones, because you could have some features of stress, some features of urge. It's kind of hard to tease those apart. And that's actually, mixed is quite common in older people. So stress incontinence is usually due to weak pelvic muscles. Okay, I'm not going to have people raise their hands because this is not the type of thing we like to talk about in public. But this is when your intra-abdominal pressure increases and you have leakage, usually just a few drops. So what raises the intra-abdominal pressure? Coughing, sneezing, laughing, sometimes even bending over. All of those things can increase your intra-abdominal pressure, and suddenly you feel a little leakage of a few drops. It's basically what happens is your internal sphincter, the one that's not under your voluntary control, is kind of overwhelmed by the intra-abdominal pressure. And your external sphincter, which is under voluntary control, can't hold it in. Okay, so you have that little bit of leakage. The way we get at this is by history. Usually it's because it's linked to doing something. Again, the coughing, the sneezing, the exercising, lifting something, and you have that little leak. That's usually stress incontinence. Most common in women, by the way. You rarely see stress incontinence in men. The reason is in women, the urethra is much shorter. And so it's much easier to have that little leakage. And again, after pregnancy, the whole pelvic floor is a little weaker in women. And so because of that, women tend to have much more stress incontinence than men do. Okay, the next most common type is urge incontinence. This is where your muscle, the detrusor muscle, is kind of contracting too much. So you're getting these urges. In stress incontinence, you don't feel the urge. You lift something and you just feel a few drops leaking out. This one is where the muscle actually contracts. You have this strong sense of urgency. And you can have loss of large amounts of urine with this. Remember, with the stress, it was a few drops only. It's just kind of a leakage. This one, you can actually have quite a bit of urine come out. You have that sudden urge and you just can't hold it. And your entire bladder just empties. Your brain is basically giving the wrong message to your bladder. The bladder isn't completely full, but the brain is kind of telling the bladder to contract. You can also see this with various types of bladder irritation. Let's say things like infections, stones, tumors can cause this type of incontinence as well. Very common in certain types of diseases that are also seen more in aging. Things like diabetes, Alzheimer's disease, it's more at the later stages, but we do see it. Parkinson's disease, again, more in the later stages of Parkinson's disease. Things like multiple sclerosis, stroke, all of these can affect the bladder and cause urge incontinence. So the last major type is overflow incontinence. This is when your bladder is full and it's just not emptying properly. And at some point, so you have this full bladder, it's not emptying, and at some point it gets so full that a few drops leak out, enough to kind of relieve the pressure, but not fully emptying. Then you're okay again for a little while, and again, you'll have more dribbling. You'll be okay again for a little while, more dribbling. So it's every time the bladder gets overfull, you'll leak. But it's not emptying, so the leakage kind of will continue many, many times a day. Two reasons why you can have this. One is your urethra is blocked. There's no way, let's say the pipe is now really narrow. You can't get that urine out because you've got this really tiny pipe to go through. Most commonly, this is seen in men, and it's usually the outlet is obstructed because the prostate is really large and is squeezing that urethra. And so you have this overflow happening because the bladder is full all the time. So a lot of men who have prostate problems, they'll have this very weak urine stream because the urethra is kind of squeezed. It's now this really narrow stream that's coming out. The second reason why you have this is because your bladder is not contracting. The outlet is fine, the urethra is fine, but your bladder is just not contracting. And this is because you have damage to the bladder muscle itself, either that or to the nerves that control the bladder. Again, these are the common diseases that we see that cause this. This is a very, very difficult type of incontinence to treat, by the way. This is the most difficult type. The weak bladder is the most difficult type to treat because you're trying to whip that muscle, but there aren't very effective treatments for that. So this is probably the most challenging one that we have. Functional is when actually your bladder control is fine, but you have difficulty walking, so you just can't get to the bathroom in time. The reasons we see this is things like arthritis. If somebody's very slow because of their arthritis, they're walking with a walker or a cane, sometimes in a wheelchair, you can imagine it just takes longer to get to the bathroom. Stroke, Parkinson's disease, patients are extremely slow. That's one of the hallmarks of Parkinson's disease. So it's just walking from here to the bathroom that might be there might take a very, very long time. In Alzheimer's disease, it's complicated. Part of it may be because of urge incontinence, because of the brain giving wrong signals to the bladder. Part of it might be just confusion. People can't find the bathroom because they've forgotten where the bathroom is. We can give very good environmental cues for this. I tell people who have Alzheimer's patients living in their home, put a picture of the toilet on the door. So that's a nonverbal cue to tell the person, okay, the bathroom is right there. Or, put a picture of something else to kind of give them cues about where to go. Environmental barriers. Again, if you have to do an obstacle race to get to the bathroom, you better give yourself a long time to do it, right? So make it easy to get to the bathroom. And in the hospital, the worst thing is restraints. Now, at least in nursing homes, basically, we are not allowed to use restraints. I'm really glad about that. Or we have to justify very, very clearly why we're using restraints and show that we're trying to stop the use of restraints. But in the hospital, it's sometimes impossible. Let's say somebody is on a ventilator and they have a tube in their throat and they have a catheter and they have IVs. You can imagine you don't want those pulled out. So sometimes people have to be restrained. But then you can't expect them to go to the bathroom. So you have to provide some other outlet. Big question, should you tell your doctor? It's actually quite alarming. The studies show that most people with incontinence do not. They do not tell their doctor. Many reasons for this. They might be embarrassed. They might think, why bother? There's nothing that can be done. Or they might just, figure this is normal aging, and I have to put up with this. And I strongly recommend that people who have this problem, please talk to your doctor about it. Even if they are not expert in it, they might be able to refer you to someone who is. So when I first see patients with incontinence, what do? Always start with history. And for history, I have to ask a lot of questions to try and pinpoint what type it is. So remember I told you my first approach is, how long has this been going on for? If it's a very short duration, I'm in a completely different mind track. If it's long duration, if it's been going on for 5 years, I'm thinking completely differently. So that's the first thing. How long has this been going on? Then I ask history about what causes it. Tell me more about it. Is it like a stress incontinence, that you're lifting something or sneezing or coughing and you have a little leakage? Again, that takes me on a different path. Are you having urge incontinence, where your bladder is kind of contracting without you wanting it to and having large amounts of leakage? Or is it an overflow, where you're having this sort of constant dribbling through the day because your bladder is not emptying properly? All of those take you on a different path. Diet. It's interesting. Some diets can really change incontinence. I've had some patients tell me if they eat a lot of acidic type of foods, they notice that their incontinence gets worse. Or if they eat a certain type of food, that their incontinence gets worse. Well, that tells you something. And I would tell them, restrict your diet, or at least, if you really love those foods, eat them when you're at home. Don't eat them when you're going out. Things like that. Fluid intake. How much fluid are you taking in? And when are you taking it in? If you're drinking lots of liquids right before bedtime, well, you're going to be up all night going to the bathroom. So I don't recommend restricting fluids because I think many older patients are kind of dehydrated, but I recommend that they shift the timing of the fluids to earlier in the day rather than later in the day. What medications are people taking? We talked a little bit about how important that is, and you might not think of it because you might say, this is a blood pressure medication. What does it have to do with my bladder? Well, unfortunately, there's side effects that affect your entire body. Are people wearing protective devices? I always ask for that. Are they wearing pads? Are they putting diapers on? Are they having to line their bed with pads because they have leakage at night? Those kinds of things. They tell me a lot too. Avoiding diarrhea is very helpful. I'll show you a sample of one. And then I always have to ask, what are your goals? Because some people, want their incontinence completely controlled. Other people are willing to wear pads every day, but they just want to be able to do certain tasks and able to live with it. So again, you have to ask the patient. It's got to be patient-centered care, right? What do they want? So this is a sample voiding diarrhea. You can actually, I was going to give you guys a sample, but you can just Google it actually. A bunch of these will show up. Again, the specialist that you go to will kind of tell you. Most people ask you to keep avoiding diarrhea for anywhere from 24 hours to about 3 days. Most people want more than just 1 day because it gives you a better idea about what's going on regularly. So this is one that includes time here. The next one is fluid intake in ounces. The next one is voiding amounts in ounces. So you have to measure. For these 3 days that you're doing this diary, you're going to have to actually measure everything. Have you had leaks or accidents? Do you get strong urges to urinate? Even if you don't leak, do you get these strong urges? And then what are you doing when you're leaking or when you're getting the urge? That's one type. I have a second type on the bottom where you actually have an hour to hour. For 24 hours, I cut it off. It was a whole page with 24 hours listed, and you have to list what happens at each hour. Again, very important because it gives us a better idea about what type of incontinence it is. And the treatments are completely different for the different types of incontinence. Under tests, I usually do a cognitive test just to make sure that the patient doesn't have an undiagnosed dementia syndrome, So I do a little bit of a memory testing. I test for depression. I usually do that anyway for most older patients as a screen, but particularly for this, I think it's important. A functional assessment, what do I mean by that? Is the person able to walk okay? Are they able to walk at a reasonable speed to be able to get to the bathroom? Or do they need help with walking? Are they able to actually sit down by themselves? Are they able to get up off the toilet after using the toilet? All of these things are things that we test for. Look at the environment. A home visit is so useful to make sure that there's no environmental restrictions for that person, to make sure that the pathway to the bathroom is clear. There's no clutter in the way. There isn't something for them to trip over and fall, especially at night, right? We hear this so often. Somebody is waking up to go to the bathroom, they're rushing because they got to go right away, and then they fall down. So again, we want to make sure that we don't have that. A good abdominal exam, a good pelvic exam for women, and a rectal exam, and then a neurologic exam. Remember I told you all of this is under the control of the brain and the spinal cord. So you want to make sure that there's no damage in the neurologic system. There are certain tests we recommend routinely. I always do some blood tests just to look at kidney function, calcium levels, glucose levels, just some basic chemistries that are pretty easy to get. I usually do a basic urine test as well. That tells me again if there's blood in the urine, I might be thinking, is there stones or tumor in the bladder, those kinds of things? Is there an infection going on? I'm thinking about those things. Urine culture if needed. Post-void residual volume is after somebody goes to the bathroom to check and see how much urine is left. Remember I said that the residual, you don't completely empty with aging. Well, if there's a lot left, that means that the person is not emptying their bladder properly. That again tells me a lot. Maybe this is overflow incontinence because they have this constantly full bladder that's not emptying properly. Urodynamic studies are done by specialists, not by me or by regular internists or primary care doctors. You have to be referred for that. I tend to use, for men who have incontinence problems, I tend to use urologists. For women, I actually prefer urogynecologists. There are urologists who also do female incontinence, but somehow the urogynecology people, I think, just have a better handle on all the pelvic organs. So I've been mostly using urogynecologists for women. They're harder to find, by the way, than urologists. There are less of them, but now I think in Hawaii where we have a reasonable number, so there is the resource there. So for general treatment, we always want to treat the underlying condition. If we know that something is causing the incontinence, treat that cause, right? That would be the simplest thing. Eliminating those medications. You can see I'm kind of on a theme here, about medications. We are, in general, geriatricians are kind of less is more philosophy for medications. Environmental assistance, make sure that there are no barriers to getting to the bathroom. Sometimes we need to provide these portable devices. If somebody is going to the bathroom at night and it's really hard for them to get to the bathroom, maybe a bedside commode is the answer, so that they can get quickly from the bed to the bathroom rather than having to walk a long way. Bedpans may be necessary, urinals may be necessary. In the toilet, if people have trouble getting up off the toilet, then having a raised toilet seat may help, or sometimes even having like hand guards around the toilet, which should be installed so that they don't move around. But you can have a carpenter or somebody come in and install those hand guards, and then you can easily lift yourself up off the toilet. This last thing on the slide is something I recommend for all types of incontinence, for everybody, no matter what the cause is. Regular timed toileting. Keep that bladder as empty as possible, no matter what the cause is, no matter whether it's temporary or permanent or established. Keep the bladder as empty as possible. You're going to be less likely to have leakage of any type. So instead of waiting, I put people on a schedule. I usually start out with every 2 hours, and then you can make it either less time or more time. Sometimes you can go to every 3 hours, or sometimes you have to make it every hour and a half or less. But give yourself a reminder to go to the bathroom on a regular basis. That automatically cuts down leaks for a lot of people. There's one exception to that, the overflow. Remember I told you those patients can't empty their bladder. So this is not going to work for those patients who have overflow incontinence, where the bladder is full all the time. Taking them to the bathroom is not going to help. They cannot empty the bladder. But for every other type, I think timed toileting is really good. What about people with Alzheimer's disease or any kind of dementia where they're not going to remember to go every 2 hours? Well, then they need to be taken every 2 hours. And the trick is not to ask, do you need to go to the bathroom? You never ever do that. You always say, it's time to go to the bathroom, and you take them. Many of you probably had children or even have grandchildren. How many times has this happened to you? I used to ask my daughter, do you need to go to the bathroom? When she was a toddler, and she'd say, no. 5 minutes later, I got to go right now. Yeah. We always had emergency supplies in the trunk of our car when we were out of the house, right? You don't wait. You just go and you tell a person that they need to go right now. So I'm going to go over each type and talk about what treatment options we have for each type. So for stress incontinence, this is the one where you sneeze, you cough, you lift something, and a few drops leak out. Well, what you need to do, your pelvic floor is weak. You need to strengthen your pelvic floor. So they've created these things called Kegel exercises that kind of exercise the pelvic floor. And the way I teach this is I tell my patients, the next time you're going to the bathroom, in the middle of going, hold it. And what the muscle that you have to contract to hold that stream, that's the muscle I want you to contract to do these exercises. To be effective, these exercises need to be done several times a day. We do them in rounds of 10, and they need to be done several times a day, so a couple of 100 times throughout the day. But you could do it anywhere you are, because all you have to do is contract that muscle. I have had some older patients tell me, I cannot stop the stream. I'm trying to teach them the Kegel, so I'm telling them, when you're going to the bathroom, stop it, and they can't. They just cannot do it. Those patients will have a much harder time with the Kegel. For those patients, biofeedback or electrical stimulation sometimes will help kind of bring those muscles back to life. Again, those are done by specialists, not by general doctors. Some patients need medications to kind of strengthen that internal sphincter, to contract it. So sometimes we can use that. And for this type of incontinence, actually, surgery or even injections around the urethra can be quite effective. Again, it's a patient preference. Do they want to have surgery or not? But it's something that the specialists can discuss with them. Urge incontinence, again, the first step is always non-medications. It's looking at behavioral therapy with bladder training at increasing intervals to see if you can actually control that urge. So what they try and do is, when they try and train your bladder, when you first get that urge, don't go to the bathroom, and use some biofeedback mechanisms to try and control it. And then you kind of gradually increase the time and see if that works. Now, if those don't work, if the behavioral therapies don't work, medications to basically relax the bladder is something that can be used. But always need to be watched for side effects. For example, all the medications that relax the bladder, they also affect the cholinergic system, which is the main chemical that is short supply in Alzheimer's disease. So if you have a patient with Alzheimer's and you put them on one of these medications, it can cause more confusion. So you have to be a little careful about balancing that. What about overflow? Well, if there's an obstruction, you need to relieve the obstruction. So if it's a prostate problem, you need to basically either treat the prostate, the enlarged prostate, with medications, or sometimes surgery is needed. If you have a weak bladder, you can try and give medications to stimulate the bladder to control, but they often don't work, unfortunately. The way I've heard the neurologists talk about is you're trying to beat a dead horse, and it's the bladder, the muscle is not viable. So I think you give it a try, but you know that sometimes it doesn't work. Double voiding can help to empty the bladder better. What does this mean? You void, you think you're done, but you wait. And then a few minutes later, you try again. And sometimes, actually, that can help because it does help empty. You're kind of doing it in 2 stages rather than 1 stage, and for some people, that can help. Sometimes you need medications to relax that internal sphincter, because sometimes that sphincter is too tight, and if the gate is too tight, you need to open it up a little bit. But the last resort is catheterization. This is a picture of a catheter. There's a balloon at the end. This is what it looks like when it's in the bladder. This is the bladder. You put the catheter in, and then you have to actually inflate the balloon so that it doesn't come out. Otherwise, the catheter will just kind of drop out. We use catheters as a very last resort. 100% of catheters get infected, 100%, if you give it enough time. So we really avoid them as much as possible and only use them as a very last resort. What about prevention? Some interesting lifestyle changes: losing weight, stopping smoking, stopping alcohol, changing your diet, less caffeine, less sugar, spicy foods, acid. I would have a lot of trouble with the spicy foods because I really love them. Preventing constipation, because that can certainly make incontinence worse. Avoiding heavy lifting, and then timing of liquids and medications. If you're on a diuretic, don't take it at night. If you're drinking a lot of liquids, don't drink them just before bedtime. Some people actually limit their activities because of fear of incontinence. So they actually don't go out of the house, and they can get isolated and depressed. And so that's why I really urge people to go get help. We don't want that. We don't want people just sitting at home because they're so concerned about leaking urine. It can lead to poor sleep. In the night, it can lead to falls with fractures because, again, people are jumping out of bed and running to the bathroom, and that's never a good thing. Skin problems, things like rash, bed sores can happen. So we do recommend sometimes pads and diapers. Cost is a factor. Those are not cheap, but they are absorbent and they kind of take the fluid away from the skin, so they help to protect the skin a little bit. And then there are many skincare products that are quite useful, actually. There are these barrier creams and cleansers. Keeping the area, if you cannot do anything about the incontinence and somebody is in a diaper, keeping that area as clean as possible is really important. So the goal is really to relieve the most bothersome symptoms, and we always do it in a stepwise way, right? First with lifestyle changes, then with behavioral therapy, then only if these don't work, moving on to drugs, and then the last resort would really be surgery. So Virginia has taught me that no matter what the topic is, we must always have a humorous component to our talks, correct? So with age comes skills. It's called multitasking. I can laugh, cough, sneeze, and pee all at the same time. I'm going to stop with that and see if anyone has any questions.